nice ECG series. It's every other week in English. So next one is the 23rd of March. Dr. Volkan, he discussed a lot of ECGs. It's very interactive. This is very nice. I really advise all of you to attend because this is really nice. On the 22nd of March, we are going to continue with Dr. Meryl Cohen Echo series. She's going to talk about imaging after surgery for single ventricle. I'm sure this is going to be awesome. And on the 25th of March, we are going to have our third meeting of fetal cardiology. And this is going to be a very practical one, very interesting topics. I hope all of you can join. And yesterday we had a very nice talk of Dr. Giovernovsky about transposition. He's going to continue this one. We are going to let you know when. And on the 1st of April, he's going to talk about clinical research. So please join us on this ICU series. It's very, very interesting. And Dr. Norman Silverman, who is our panelist today, is going to continue his imaging series. He makes a very nice correlation of morphology and echo images. So he's going to talk about the tetralogy of Fallot on the 12th of April. The last one was about anomalous pulmonary venous connections. It's on YouTube. You can take a look. It was very, very nice. And we are very happy to have Dr. Anderson with us every Friday with Dr. Diane Spicer and a lot of nice panelists. So we are going to start today's talk. So please, guys, type your questions on the Q&A chat box, and we are going to be happy to discuss all of your questions in the end of the session. Please enjoy.
Well, good afternoon to you all, ladies and gentlemen. You will all know that last week we were joined by Diane Spicer, and she showed you a superb series of video presentations illustrating the anatomy to be discussed. Well, I'm pleased to be able to tell you that Diane will join us again today. And as you can see from the image I have on the screen at the moment, we're going to be discussing a contentious lesion. You will all know from our recent discussions that several entities have been contentious according to the way we describe them, according to the way we classify them. But I think it is still the case that perhaps the most notorious is those lesions we call single ventricle. And as you all know, Meryl is going to be talking to you in a week or so about the echocardiographic approach to post-operative patients that allegedly have single ventricle. So it's important that we understand precisely what we are talking about, because what we're going to show you today is that almost all of the patients that many of you still describe as having, quotes, single ventricles, close quotes, have one big and one small ventricle. And it is my belief that the problems that existed in the past were resolved by recognizing that what we are talking about is a functionally single ventricle. But today, we're going to discuss the anatomy that underscores that approach. So if we are to bring understanding to the situation, we need to start off by looking at ventricular morphology. We need to ask the question, what is morphologic nature of the ventricle that pumps the blood into the circulation? More importantly, when we're talking about potential single ventricles, we need to ask, is there a second ventricle present? What we're going to concentrate on today also is the importance of analyzing the atrioventricular junctions. And here, the question is, in these settings, do the atrial chambers connect to only one ventricle, or do they connect to both ventricles? And above all, we need to describe what is going on in logical fashion. So today, we hope to set the background for these discussions on the basis of those hearts that have a dominant left ventricle. Why am I starting with the dominant left ventricle? Because Those of you who have been watching in recent weeks will know that I've shown you the evidence that during development, the embryo itself initially has a heart with double inlet, developing left ventricle, double outlet from the developing right ventricle. So at the outset, the developing normal heart is functionally univentricular. And all the problems that we have in the past related to that second chamber in the presence of a dominant right ventricle. Is it an incomplete right ventricle, or is it no more than the infundibulum? So let me share with you again the developmental background to this contention. You'll remember I've been showing you these images demonstrating the cavities of the developing heart, and here you see the situation just at the beginning of the 5th week of development, what we call Carnegie stage 11. I remind you again, these images come from interactive PD files made by Professor Wout Lammers, Dr. Jill Hickspoors, and they work in Maastricht University in the Netherlands. So here we see the cavities at the beginning of formation of the ventricular loop. There is the ventricular loop. It has an inlet through the atrioventricular canal, and at its outlet, it supports the outflow tract. We can go on 2 stages of development. So here we're halfway through this 5th week of development, as you see, 32 days. And now the atrioventricular canal is entering that part of the ventricular loop from which we see the formation of the apical trabecular component of what will be the left ventricle. And there, from the outlet part of the ventricular loop, you see the beginnings of the apical part of what will become the right ventricle. And it is this formation of the apical component of the right ventricle that at this stage is incomplete, that is going to be the key for understanding today's discussions. Again, let me remind you rather that at this early stage, not only does the developing heart have double inlet through the atrioventricular canal, it has double outlet through the outflow tract. So I've shown you this image several times before. This is an image through one of our episcopic data sets. I've cut through the base of the ventricular mass so that you can view it from the apex. And there you see the atrioventricular canal. And we know at this early stage, it's supported by the developing left ventricle. There you see formation of the apical component of what will become right ventricle, and it is supporting the outflow tract. But this is the key view of this developing heart. It is the equivalent of what you as echocardiographers can produce by the oblique subcostal cut. There you see the cavity of the developing right atrium. And at this early stage, because the atrioventricular canal is supported exclusively by the developing left ventricle, the right atrium has no communication with the developing right ventricle. There is the absence of the atrioventricular connection at this early stage. But already, as we've already discussed, the developing right ventricle does possess its developing apical component. At this stage, it's supporting the entirety of the outflow tract, but here is the key. It has an inlet, but that inlet effectively is the interventricular communication. And we're going to be seeing this as DIANE shows you the specimens to illustrate the anatomy of hearts having a dominant left ventricle. So let me also remind you of this image in which we were able to prove that the entirety of the right ventricle came from that distal part of the ventricular loop. You'll recognize right atrium, left atrium. As we have seen, the atrioventricular canal supported exclusively by what will be the dominant left ventricle. So there is the right ventricle, and it is incomplete at this stage because it lacks its own inlet component. the inlet is effectively the interventricular communication. But what we're also going to look at is the influence of atrial septation. Because as I'm going to show you, and as you will see in the specimens, it is the direction of the atrial septum that has an influence on how the atrial chambers connect to that dominant left ventricle. So let me show you that by taking this 4-chamber cut through another of the episcopic data sets. This time I'm showing you one of our episcopic data sets from a human heart at Carnegie stage 14. And there you see the atrioventricular canal. In this heart also, it has retained its connection with what will become the dominant left ventricle. Again, you can see that the developing right ventricle has its apical component, but its effective inlet is the interventricular communication. Now, what we are going to be concerned about today is what happens to the vestibules of the atrial chambers that connect with the dominant left ventricle. And everything is going to depend on the orientation of the atrial septum. Because at this stage, we have double inlet through a common atrioventricular junction. As you see, the vestibules of the developing right atrium, the developing left atrium are connected and supported by that dominant left ventricle. But if the atrial septum grows down and divides that junction, still with the junction being supported by the left ventricle, we would have to double inlet through separate atrioventricular junctions. However, if the atrial septum grows in such a way as to sequestrate the cavity of the right atrium from that atrioventricular junction, it will no longer be a common atrioventricular junction, it will be a left atrioventricular junction. And DIANE is going to show you by illustrating that arrangement it what we call tricuspid atresia. But on the other hand, if the atrial septum grows in such a way to sequestrate the left atrium, then that junction will be a right atrioventricular junction. It will no longer be common. The right atrium will connect to a dominant left ventricle. We don't have hearts for DIANE to demonstrate that to you today, but I will show you some of my images. So what we are going to talk about is the fashion in which that atrioventricular junction is connected into the dominant left ventricle. And we're going to start off by looking at this lesion again. DIANE showed you this heart on previous occasions. It's a heart that has classical tricuspid atresia. And this relates to the bone of contention, because we've always believed in tricuspid atresia, that small chamber was the right ventricle. Whereas in the setting of double inlet left ventricle, previously it was thought to be an infundibular outlet chamber. So was that presumption justified even in the setting of tricuspid atresia? And I don't believe it was, because what DIANE is going to start off by doing is by showing you the difference in the morphology of that chamber known to be the right ventricle in the setting of tricuspid atresia when there are concordant as opposed to discordant ventriculo-arterial connections. So now we're going to look at our first specimens.
Hearts with the classic type of tricuspid valve atresia have an absent right atrioventricular connection, so that this atrioventricular connection is univentricular with two ventricles within the ventricular mass. So we have one small ventricle and one larger left ventricle. The right ventricle lacks its inlet, and in the past, the right ventricle, when associated with classical tricuspid atresia, was always considered as a right ventricle. And as we'll see within our discussion today, that the incomplete rudimentary right ventricle that we see in those hearts with double inlet left ventricle were not given such status, and this was a controversial point. The apical trabecular component in hearts with classical tricuspid atresia is typically rightward. You can see the well-formed subpulmonary infundibulum in this specimen, and there is a ventricular septal defect that is extending into the inlet component. The ventriculo-arterial connections are most often concordant in classic tricuspid atresia as they are in this specimen, and the ventricular septal defect can be clinically significant if it is quite restrictive and obstructs flow to the pulmonary artery that would come from the left ventricle, as this interventricular communication is the only inlet to the right ventricle. There is absence of the right atrioventricular connection, as we can lift the atrial musculature directly off the ventricular mass. And within the floor of the right atrium, there is typically a small dimple in the area where the atrial musculature connects with the ventricular mass. A lot of times we have an associated malformation at the floor of the oval fossa with deficiency of the flap valve, so that in this particular case we have a so-called secundum type of atrial septal defect. In hearts with tricuspid valve atresia, there's an absent right atrioventricular connection and an absent right atrioventricular valvar orifice, so that the atrioventricular node is found adjacent to the dimple, which is typically at the apex of the triangle of Koch. If we see here the coronary sinus, then you can imagine that the tendon of Todaro runs in this area and points directly at that dimple. Placing a pin in the dimple shows us that that pin exits within the left ventricular outflow tract and along the posterior inferior border of the ventricular septal defect or interventricular communication, so that the conduction axis would penetrate at the junction between the muscular atrial floor and the ventricular mass and run along the posterior inferior aspect of this muscular ventricular septal defect, which is in the inlet component of the right ventricle. This particular specimen has tricuspid atresia with discordant ventriculo-arterial connections. The aorta arises from the small right ventricle. You can see the brachiocephalic arteries from the aortic arch. This case also had a Blalock-Taussig shunt because the patient had coexisting pulmonary atresia. There is no connection between the right atrial floor and the ventricular mass. In fact, you can see the coronary artery arising from the anterior aorta and extending in the right atrioventricular groove. The small right ventricle is arising in a more anterior position than in the specimen that had concordant ventriculo-arterial connections. And you can see that the apical trabecular component is in a bit more anterior position than in the last heart. There is a muscular interventricular communication with posterior deviation of the outlet septum, most likely the cause of the pulmonary atresia. The aortic valve in this particular case is supported by a complete muscular infundibulum, and as I said, there's posterior deviation of the outlet septum. The right coronary orifice is here, and the left coronary orifice just there. There were issues during development with proper transfer of the arterial trunks to their appropriate ventricles, yielding transposition of the great arteries. The pulmonary trunk, if we look at the short axis, is here, and it has been cut to show that there is pulmonary atresia. The floor of the right atrium has been exposed, and the dimple is easily seen in this area of the floor of the right atrium. The left atrial appendage is morphologically normal with its narrow attachment to the smooth atrial vestibule, and you can see the large dominant left ventricle within the ventricular mass. The conduction axis can be marked at the dimple at the right atrial floor, where the right atrial musculature joins the ventricular mass. Here we can see the coronary sinus at the base of the triangle, and the eustachian valve has been mostly cut away, but you can appreciate that prominent tendon of Todaro, which points towards the dimple. If a pin is placed in the dimple at the muscular atrial floor and at the apex of the triangle of Koch, we can see from the right ventricle that the pin is within the left ventricle, and it is at the junction between the muscular atrial floor and the crest of the muscular ventricular septum, so that the conduction axis will run along the posterior inferior border of that muscular outlet ventricular septal defect.
So, what you have now seen is that in the setting of tricuspid atresia, when it has always been accepted that small chamber is right ventricle, it varies in its morphology according to whether there are concordant or discordant ventricular arterial connections. So is it the same when we have double inlet to the left ventricle? And what we're going to see is that the same variation in morphology is found. So what DIANE is now going to do, she is going to show you the classical example of double inlet left ventricle, which is associated with discordant ventricular arterial connections. And then she will show you the heart you've seen several times before. It's a variant of the so-called Holmes heart. In the one that she'll show you, there is straddling of the right atrioventricular valve. But what I want you to look at when she shows you these specimens is the difference between right ventricle when we have the Holmes heart variant with concordant ventricular arterial connections, and the heart that she's going to show you initially, in which we have double inlet left ventricle with discordant ventricular arterial connections, or in other words, double inlet left ventricle with transposition.
This heart has double inlet left ventricle with discordant ventricular arterial connections. The aorta is exiting directly anterior to the pulmonary trunk. There is a small right ventricle on the anterior superior aspect of the heart, or on the shoulder of the heart, with the aorta arising from it. In the past, this hypoplastic, rudimentary and incomplete right ventricle was denied ventricular status in hearts with double inlet left ventricle, and that was a point of controversy. This rudimentary right ventricle has an apical trabecular component, and in hearts with double inlet left ventricle, the apical trabecular component can point to the right, can lie anteriorly or more towards the left. This hypoplastic right ventricle lacks its inlet component, but still has right hand ventricular topology. If I place my right hand on the septal surface, my thumb goes towards the inlet and my fingers towards the outlet. The interventricular communication is quite large in this case, allowing for good egress of blood to come across the defect and out the aorta. This specimen has usual atrial arrangement with a morphologically right atrial appendage to the right and a morphologically left atrial appendage to the left, so that there is usual atrial arrangement. And in hearts with double inlet left ventricle, both atrial vestibules are connected to the dominant left ventricle. And this is secondary to retention of the initial embryonic connections of the atrioventricular canal to the developing left ventricle. So within this dominant left ventricle, I've opened it now in clamshell fashion. There is the right atrioventricular valve and the left atrioventricular valve. They are typically supported by their own papillary muscles, and there are usually no attachments to the interventricular septum. When there is a shared papillary muscle, this can make it difficult for the surgeon when they're trying to divide this dominant left ventricle. The ventricular septal defect or interventricular communication is on this anterior wall that I've lifted up, and this is the interventricular septum. Secondary to the left ventricular dominance, the atrioventricular conduction axis is grossly abnormal, and that's secondary to the lack of a ventricular septum extending to the crooks, so that you can see that this muscular apical ventricular septum does not extend to the crooks. Here is the pulmonary valve forming the outlet of this dominant left ventricle, and secondary to the ventricular septum not extending to the crooks, the ventricular components of the conduction axis are carried on the crest of the apical muscular ventricular septum, with the atrioventricular node formed at the junction between the apical septum and the atrioventricular junction, or where the ventricular septum meets the atrial myocardium. And that aberrant atrioventricular node will be in this area, and the conduction axis will run along the crest of the ventricular septum. Looking within the right ventricle, the conduction axis will emerge and run along the crest of the ventricular septum. If you participated in the discussions over the past couple of weeks, you'll recognize this beautiful specimen prepared by Dr. Van Merritt from the University of Florida. You'll note that the right ventricle is small and the left ventricle is the dominant ventricle in this particular heart. The arterial trunks are normally related, and there are concordant ventriculo-arterial connections, so that the pulmonary trunk exits the right ventricle and the aorta the left ventricle. And you'll note that they spiral in normal fashion. The right ventricle, as I said, is hypoplastic with its apical trabecular component towards the right. There is right-hand ventricular topology. I can put my right palm on the septal surface with my fingers in the outlet and my thumb in the inlet. So right-hand ventricular topology. You can see the interventricular communication with the right atrioventricular valve straddling and overriding the ventricular septum. Looking within the right atrium, the right atrioventricular valve straddles the interventricular septum, which you can see here running the entire length of the right atrioventricular junction. The right atrioventricular valve is partially committed to the right ventricle in its lesser part, and mostly committed to the left ventricle, secondary to the atrioventricular septal malalignment. Looking at the dominant left ventricle, here is our left atrioventricular valve, and supported by its own papillary muscles. The right atrioventricular valve has its chordal attachments straddling the ventricular septum and has a few attached to the crest of the ventricular septum, and it is committed in its greater part or greater than 50% to the left ventricle. So that places this specimen in the category of a double inlet left ventricle. The atrioventricular valves are typically adherent to one another as they enter the dominant left ventricle, and they're typically in fibrous continuity with the arterial valve that leaves the dominant left ventricle. And in this particular case, it is the aorta. When there is a double inlet to a dominant left ventricle with concordant ventriculo-arterial connections, this is known as the Holmes heart.
So I've shown you at the outset that we know during normal development, the developing heart has double inlet left ventricle. And we've seen that that is because the atrioventricular junction at that stage is supported by the developing left ventricle. But what I've also suggested to you is that we can have that connection with a common atrioventricular junction, as we see from the outset of development. But if the atrial septum grows in such a way as to separate that junction, the junction itself remaining committed to the left ventricle, we will have double inlet left ventricle with two atrioventricular valves. And indeed, that is what usually happens. And the key point here, the number of atrioventricular valves does not change the atrioventricular connection. Now I can illustrate that to you by comparing atrioventricular septal defect, with which you are all familiar, with the normal heart. So here, to your left hand, you see a 4-chamber cut through a heart that has atrioventricular septal defect, the typical form of atrioventricular septal defect. And you know that the essence atrioventricular septal defect is the commonality of the atrioventricular junction. To your right hand, you see a 4-chamber cut of the normal heart. And you're all well aware, in the normal heart, we have separate right atrioventricular junctions and left atrioventricular junctions. But you're all equally well aware that despite the fact, to your left hand, you see a common atrioventricular junction, to your right hand, you see the normal heart with separate atrioventricular junctions. That does not alter the atrioventricular connections, because in each of these hearts, the morphologically right atrium is connected, morphologically right ventricle. The morphologically left atrium is connected to the morphologically left ventricle. The presence of the common junction does not alter the atrioventricular connections. And that is exactly the same when we have double inlet atrioventricular connection. So what now DIANE is going to show you, she's going to start off by showing you again the typical arrangement in double inlet left ventricle, when we have two atrioventricular junctions, both connected to the dominant left ventricle. And then she's going to show you two hearts that have double inlet left ventricle through a common atrioventricular valve, but with the common atrioventricular junction still supported exclusively by the dominant left ventricle in the presence of a second incomplete right ventricle.
This particular specimen has absence of the majority of the atrial chambers, and the arterial trunks have been cut just above the arterial valvar attachments, and this patient had this heart removed and a new one implanted. The anterior superior incomplete right ventricle has been windowed in this particular case, and you can see that it gives rise to the aorta. There is the right coronary artery and the left coronary orifice in this position. So there is transposition with the aorta supported by a complete muscular infundibulum within this rudimentary incomplete right ventricle, and the apical trabecular component pointing anteriorly. You can see that there is a large interventricular communication, which would allow the necessary blood flow to go into the aorta. I have this specimen cut in a 4-chamber plane to show you the double inlet into this dominant left ventricle. This is the right atrioventricular valve. You can see some of the pectinate muscles remaining at the floor of the right atrium. And here is the left atrioventricular valve. You can see that there's a fibrous raphe between them as they enter this dominant left ventricle, and they are both supported by their own papillary muscles. The opposite aspect shows us the ventricular septal defect. Again, you can see the right atrioventricular valve with the pectinate muscles in the right atrial appendage, and here is the left atrioventricular valve, which has a few tendinous cords attached to the crest of the ventricular septum. This specimen shows us nicely the double inlet to the dominant left ventricle with its fine apical trabeculations and the smooth septal surface up towards the outlet of the ventricle. The pulmonary valve is in this position just between the two atrioventricular valves, with fibrous continuity between both of the atrioventricular valves. This specimen is quite interesting and will demonstrate that you can see quite a degree of variation in associated defects in hearts that have congenital malformations. This particular specimen had its apex pointing to the right and was sectioned so that we could look at it along the short axis of the ventricular mass. You'll note that the aorta arises anteriorly and from the smaller ventricle within the ventricular mass. Tilting the specimen to look at the right side, the pulmonary trunk exits posterior to the aorta and has a tortuous arterial duct, the aortic arch extended to the right. There is juxtaposition of the atrial appendages to the left of the arterial pedicle and shows us just one of the variations that we can see within the atrial chambers. The right sided portion of the right atrium admits the superior caval vein to its roof and the inferior caval vein to its floor, so that this would be the diaphragmatic aspect. Looking at the left side, we'll note that there is a persistent left superior caval vein. Folding back the wall of the left atrium shows us the persistent left superior caval vein joining its roof. The wall that typically separates the persistent left caval vein from the left atrium is absent, so that we end up with unroofing of the coronary sinus and a very large interatrial communication at the level of the coronary sinus. This is the oval fossa with a deficient flap valve, and there is a so-called secundum type of atrial septal defect. Looking at the atrioventricular junction, there is a small remnant of the atrial floor here. Both atrial vestibules, the right and the left, are connected to a dominant left ventricle via a common atrioventricular valve. Looking at the short axis apical view, as I mentioned, there's a rudimentary incomplete right ventricle that sits on the shoulder of the heart or in anterior superior position. And here we see the dominant left ventricle. The zone of apposition between the superior and inferior bridging leaflets is pointing directly at the interventricular septum. The majority of the specimens we've looked at have had usual atrial arrangement, and there was one with juxtaposition of the atrial appendages to the left of the arterial pedicle. This specimen has isomerism of the right atrial appendages with the apex of the heart pointing to the right. The superior and inferior caval veins were left-sided, and you can see this blunt appendage with the broad attachment to the venous component and the pectinate muscles within the appendage on this anterior most atrium. Looking at the more posterior atrium, it as well has a blunt appendage with a broad attachment to the venous component and hepatic veins draining into the floor of this posterior most morphologically right atrial appendage. There is also transposition with pulmonary atresia, so we can see this anterior aorta with a right aortic arch. Posterior to it and to the right, we see the pulmonary trunk, and there is pulmonary atresia. This heart was sectioned kind of in an oblique, apical, short axis view, where you can see the dominant left ventricle with the fine apical trabeculations and the small posterior or leftward ventricle that is the right ventricle. It is incomplete and rudimentary, but there are apical trabecular components, and the aorta does exit the right ventricle. This double inlet left ventricle is guarded by a common atrioventricular valve. You can see the zone of apposition pointing directly at the muscular interventricular septum, and the interventricular communication between the dominant left ventricle and the right ventricle is in this area. If I lift this up, there is the small little dimple where the pulmonary trunk would have exited this dominant left ventricle. The ventricle that is posterior, or the right ventricle in this case, has left-hand ventricular topology. Even though it lacks its inlet, we can still put the palm of my hand on the septal surface with my fingers in the outlet and my thumb towards the inlet. So left-hand ventricular topology in this particular case.
So, having looked at Diane's presentations showing us the difference between separate AV junctions, common AV junctions, when they're connected to a dominant left ventricle, you will also have appreciated that the presence of the double inlet atrioventricular connection does not change according to the atrial arrangement, because what she has shown you is hearts with usual atrial arrangement, and you've seen a heart that has mirror-imaged atrial arrangement. Sorry, I take that back. She's shown you a heart with usual atrial arrangement, and she showed you a heart that has isomeric right atrial appendages. But it is also possible to have double inlet with mirror-imaged arrangement or with isomeric left atrial appendages. The morphology of the atrial appendages does not change that key point, the atrioventricular connection, and that depends on how the atrial vestibules are connected to the ventricular mass. And in the setting of double inlet, both of those vestibules are connected. Same ventricle, in this instance, the dominant left ventricle. So what you have now seen is that double inlet, most usually, is found with two atrioventricular valves. In our opinion, those valves are best described as being right valve, left valve. You've also seen that there can be a common valve. But now, what we're going to look at is the fact that those valves in themselves can be abnormal. So Diane is now going to show you examples where the right and left valves are stenotic. The heart with the stenotic right valve is particularly important because it's very similar to tricuspid atresia. And Diane is going to illustrate that point. And then she's also going to show you a heart that has straddling of the left atrioventricular valve. Now you've seen already a heart with straddling of the right atrioventricular valve. That was the Holmes heart. So now she's going to show you, having seen the hearts with stenosis of the right and left valves, she's going to show you an example of straddling of the left atrioventricular valve. And indeed, she will also show you that stenotic left atrioventricular valve is itself also straddling and overriding.
This specimen very much resembles the specimen we first looked at that had tricuspid valve atresia with concordant ventriculo-arterial connections. This specimen has discordant ventriculo-arterial connections, and the aorta arises from the right ventricle. There's the right coronary orifice there. The right ventricle looks very much like that right ventricle in the heart with tricuspid valve atresia, and the apical trabecular component is pointing towards the right. There are two muscular ventricular septal defects, one in the outlet component and one in the inlet component and slightly inferior. The aorta is supported by a complete muscular infundibulum. The right atrium can be lifted off of the ventricular mass. There's the right coronary artery running in the atrioventricular groove. And I also should mention that this specimen has right hand topology so that I can put my palm from my right hand on the septal surface with my thumb towards the inlet and my fingers towards the outlet. Even though this right ventricle is lacking an inlet, it still is given ventricular status because of its apical trabecular component and its outlet component. The right atrium shows us a small stenotic valve. At its inlet, there's the oval fossa, and if I probe this small right atrioventricular valve and look into the dominant left ventricle, you can see the probe entering the left ventricle. Here is the left atrioventricular valve. And now we can see that very stenotic right atrioventricular valve entering the dominant left ventricle. All of the chordal attachments are within the left ventricle, and there is fibrous continuity between the two atrioventricular valves. The pulmonary artery exits this dominant left ventricle, and there you can see the larger of the two muscular ventricular septal defects, this one the outlet defect, and the other the muscular defect towards the inferior surface of the heart. We're looking at the base of the heart, and the majority of the atriums have been removed secondary to transplantation. Here we can see the pectinate muscles extending around the right atrioventricular junction, and the majority of the left atrium and its appendage have been removed. You'll note that the right atrioventricular junction is much larger than the left, so that we have stenosis of the left atrioventricular valve in this particular case. The pulmonary trunk is here, and the aorta is directly anterior to it, so that this specimen again has transposition of the great arteries. There's the right coronary orifice in proof that this is the aorta. The specimen has been sectioned in a roughly 4-chamber plane, so I can open it in clamshell fashion to show you the aorta exiting this small, incomplete rudimentary right ventricle, So that here's the crest of the interventricular septum here and here anteriorly. The interventricular communication would be in this particular region. The right atrioventricular valve, as we saw from the base, is the larger of the two valves. It's supported by its own papillary muscles. The left atrioventricular valve is quite stenotic, with the majority of that valvar orifice committed to the dominant left ventricle. The interesting feature is that the majority of the valve is supported across the interventricular septum and within the rudimentary and incomplete right ventricle. Looking at this specimen from the anterior aspect, there is our rudimentary or incomplete right ventricle sitting on the shoulder of the heart or in anterior superior position. The apical trabecular component is pointing mostly anterior, and there is a large interventricular communication. The aorta in this particular heart with transposition is supported by a complete muscular infundibulum. We'll note also that there is a single coronary artery in this particular case, showing us that multiple systems can be affected with anomalies in patients with congenital heart disease. The right coronary extends to the right atrioventricular groove. A second branch marks the interventricular septum or the anterior interventricular branch, and then this third branch extends across the right ventricular outflow tract to supply the circumflex running in the left atrioventricular groove. This particular heart is also as a result of a transplant and was cut in 4-chamber plane. You'll again see that the majority of the atrial chambers have been removed, and in this particular cut, the inferior aspect is here. The pectinate muscles and the coronary sinus can be seen within the floor of the right atrium. The right atrioventricular valve and the left atrioventricular valve are easily appreciated, and you can see the inferior atrial buttress where it joins the ventricular mass. On this view, we're looking at the anterior aspect of the heart, so from the spine towards the sternum, and this patient had a Fontan procedure prior to transplantation. Within the right atrium, you can appreciate the pectinate muscles, and here's the right atrioventricular valve. The left atrioventricular valve is also committed to this dominant left ventricle and has a portion that is straddling and overriding into the rudimentary anterior superior right ventricle. So that area there is the interventricular communication, and this is the crest of the apical muscular ventricular septum. So a straddling and overriding of the left atrioventricular valve in this heart with a double inlet left ventricle.
Now, throughout the demonstrations of DIANE, she has been emphasizing to you that we can also use the concept of ventricular topology when we are looking at hearts that have a dominant left ventricle. And in this instance, we have to use the ventricular septal defect or the interventricular communication as the inlet to that right ventricle. And what we're going to look at next week is that in the setting of straddling valves, and now you've also seen hearts with double inlet left ventricle that have straddling valves, there are spectrums of malformation depending on the extent of the overriding of the straddling atrioventricular junction. And here again, ventricular topology becomes very important, because when the big ventricle, as we're looking at today, is the dominant left ventricle, then if that right atrioventricular valve is straddling, as you have seen in the setting of the Holmes heart and Mirop heart, if more of that straddling right atrioventricular valve was committed to that right ventricle, then we would have concordant atrioventricular connections. But DIANE has also shown you a very nice example in which the incomplete right ventricle was left-sided and there was straddling of the left atrioventricular valve. Now, in the setting of left-handed topology, we know that that valve would be the tricuspid valve. So in that instance, if more of that valve got into the incomplete right ventricle, then we would have discordant atrioventricular connections. In other words, congenitally corrected transposition. And indeed, next week, we're going to concentrate, sorry, not next week, the week after next week, we are going to concentrate specifically on the morphology of hearts with straddling atrioventricular valves, and we're going to emphasize the importance of recognizing ventricular topology, and we're going to look at those spectrums in some detail. But it's also important to remember ventricular topology in today's setting when we have double inlet to a dominant left ventricle. Because we have seen that in the Holmes heart, we can have concordant ventricular arterial connections. Indeed, it is the presence of those concordant ventricular arterial connections that gives us what we call the Holmes heart, but there we have right-handed topology. Now, when the incomplete right ventricle is left-sided, again, on very rare occasions, we can have concordant rather than discordant ventricular arterial connections. So here, topology is important, but this time there is another reason why we need to recognize this. Because in my experience, when we find concordant ventricular arterial connections in the setting of usual atrial arrangement, double inlet, left ventricle, and left-sided incomplete right ventricle, those arterial trunks are parallel rather than spiraling as in the setting of the Holmes heart. Now, we don't have a heart for DIANE to demonstrate at this point, so let me show you images of such a heart. Here I've opened the dominant left ventricle. There it is. You'll recognize its fine crisscrossing apical trabeculations. And you'll also recognize from what DIANE has shown you that we see the typical features of double inlet. There is the right atrioventricular valve, there is the left atrioventricular valve, both connected to the dominant ventricle. But in this instance, the arterial trunk arising from the dominant ventricle is the aorta. And in this setting, as DIANE has emphasized, both of the atrioventricular valves are in fibrous continuity with the arterial valve that is arising from the dominant ventricle, and it is the aortic valve. There you see the interventricular communication, and we know the interventricular communication is the inlet for the incomplete right ventricle. And here in this heart, there you see the incomplete right ventricle, and it is left-sided. So now when you put your thumb in that interventricular communication, your fingers up the pulmonary trunk, this time it is the left hand that goes on the septal surface of the incomplete right ventricle. So we have concordant ventricular arterial connections. In this instance, however, as the arterial trunks extend into the mediastinum, they do so in parallel fashion. So the pulmonary trunk, rather than spiraling as it was in the Holmes heart, is running up left-sided and parallel to the aorta. Concordant ventricular arterial connections with parallel arterial trunks. Some would call this anatomically corrected malposition. I much prefer simply to call it concordant ventricular arterial connections with parallel arterial trunks. And then the influence of topology is also important when we consider absence of the left atrioventricular connection. Now, at the outset, I told you it was the orientation of the atrial septum that determined whether the atrioventricular junction was left junction, as in tricuspid atresia, a common junction or double inlet, as what we've been looking at over the last minutes. But we can also have the situation where the atrial septum develops in such a way as to sequestrate the left atrium, leaving that atrioventricular junction as the right atrioventricular junction. And this again is usually found with left-sided incomplete right ventricle. We don't have a specimen here again for DIANE to show you, but the heart is once more indicative of left-handed topology, and many will call this tricuspid atresia with L looping. So again, I have some still images to show you. And here we have that dominant left ventricle when the atrial septum has grown in such a way as to leave the atrioventricular junction, connecting only the right atrium with the ventricular mass. So it is the right atrioventricular junction. So there you see the dominant left ventricle. And there is the valve that is guarding this right atrioventricular junction. So now it is a right atrioventricular valve. The dominant left ventricle is supporting the pulmonary trunk in this instance. We have discordant ventricular arterial connections, and there is the left-sided interventricular communication. So we look on the left anterior shoulder of the heart, and there we find the incomplete right ventricle. Its inlet is the interventricular communication. So as DIANE has shown you in this instance, you can put your thumb in that inlet, interventricular communication, with your fingers up into the outflow tract, in this instance the aorta, and your palm on the septal surface of the incomplete right ventricle. And so when, in this instance, you put your thumb in that interventricular communication, your palm on the septal surface of the incomplete right ventricle, your fingers on the aorta, you'll see it is the left hand that goes on this septal surface. So we can make the inference that this example, as with most cases of double inlet left ventricle, this heart also had left-handed topology. But in this instance, there is absence of the left atrioventricular connection. You will recognize there the morphologically left atrial appendage, and in fact, there is a dimple at the site of where the atrioventricular connection should have been. There has been an atrial septectomy in this heart, but the atrial septum was arranged in such a way as to sequestrate the left atrium from the atrioventricular junctions. So the persisting atrioventricular junction was a right atrioventricular junction. Right atrium connected to the dominant left ventricle with left-sided incomplete right ventricle. Had that valve developed on this side, almost certainly it would have been a tricuspid valve. So many will consider this to be tricuspid atresia with L looping. So what we've shown you this afternoon is the variations to be found when the atrial chambers are connected to a dominant left ventricle. What we have shown you is that that connection, both atrial chambers to the dominant left ventricle, or connection of the atrioventricular junctions to the dominant left ventricle, is one form of univentricular atrioventricular connection. We've shown it to you mostly with double inlet, but you've also seen it in the setting of tricuspid atresia. And I've just shown you an example of where we can consider the heart to show tricuspid atresia with L looping, absence of the left atrioventricular connection. And in all these instances, there is a second chamber present. So they are not single ventricles, they are functionally single ventricles because that second chamber is the incomplete right ventricle. And to emphasize again, you can have this arrangement, double inlet, with absence of the right atrioventricular connection, more rarely with absence of the left atrioventricular connection. We've also shown you there can be variation in the ventricular arterial connections. What I hope you've appreciated now is that it is this variation in the ventricular arterial connections that changes the morphology of that incomplete right ventricle. And what we have also introduced is that there can then be spectrums from hearts with double inlet ventricle to either concordant or discordant atrioventricular connections. So next week, we're going to be looking at the same variation in terms of a dominant right ventricle. We're going to show you examples of double inlet right ventricle. We're going to compare that with dominant right ventricle with absence of the left atrioventricular connection, a variant of hypoplastic left heart syndrome. We're going to look at dominant right ventricle with absence of the right atrioventricular connection. And we'll also introduce the fact the double inlet right ventricle, as we've seen today, can be found with a common atrioventricular junction or with separate atrioventricular junctions. And then the week after that, we're going to come back again. We're going to look at, in much more detail, the hearts that have straddling and overriding of atrioventricular valves. But hopefully, in today's presentation, we have set the scene for the understanding of those hearts that have one big ventricle and one incomplete ventricle. Today, looking at those hearts in which the big ventricle has been the dominant left ventricle.
So Norman.
Yes. Thank you very much. As usual, I'm grateful that these sessions are recorded so that I can look at this again a second time. The very complicated and complex description, but beautifully demonstrated. I would like to congratulate DIANE particularly on the spectacularly clear pictures that she did today, which I think have exceeded anything that we've seen before, and maybe she has a different camera, but it's really quite remarkable. The two things that came of interest to me is that we've been previously concerned that a morphologically left ventricle has a morphologically left atrioventricular valve, and a morphologically right ventricle has a morphologically right atrioventricular valve, mitral and tricuspid valves. In the presence of double inlet, what is the morphology of the valves, or do we just regard them as a left and a right AV valve? And we haven't really concentrated on that, but Bob, perhaps you can tell us whether these valves are really like mitral valves. Are they like tricuspid valves? And I appreciate you commenting on that. The other issue that was interesting to me is that there was certainly fibrous continuity between some of the atrioventricular valves that you've shown. And I think that sort of brings out what you said last week about the phenotypic feature of a ventricular septal defect. And one can see how that defect remains as such in a perimembranous ventricular septal defect. So if you could comment on those features for us, I'd be most grateful.
Well, in fact, I did comment at one point during my presentation when I said that for the very reason that you have given, that we would prefer to call those valves the right valve and the left valve. I mean, you make a very good point that when you have separate atrioventricular, when you have separate ventricles, separate atrioventricular junctions, and either concordant or discordant atrioventricular connections, then it is the case that the atrioventricular valve goes with its ventricle. So in those settings with biventricular atrioventricular connections, I think you're justified in saying that if you find a valve that looks like a morphologically tricuspid valve, then almost certainly that is indicative that it's in a morphologically right ventricle. Well, if we have a dominant left ventricle, then both of those valves are going to try to assume the characteristics of the valve that goes into the normal morphologically left ventricle. And it is indeed the case that they both look like mitral valves. And you know very well, as an echocardiographer, one of the features that you look at in the setting of double inlet left ventricle is that those leaflets clap together, do they not? And that is one of the things you are looking for. And that's because those leaflets lack septal attachment that you find in the setting of the normal tricuspid valve. That is how you recognize the tricuspid valve. It's septophilic. That's the Richard van Praag makes the point. The mitral valve is septophobic. The tricuspid valve is septophilic. So when you lack a septum coming to the inlet of the coming to the crux of the heart, both of the valves resemble mitral valves. We did a study a very long time ago now. We had BSc students who joined us on one occasion when I was still at the Brompton Hospital, and we had one young BSc student called Alan Doherty. And Alan looked at the valves in the selection of double inlets we had at the Brompton Hospital at that time. And if you look very carefully, there are subtle differences suggesting that one of the valves is trying to be the tricuspid valve. And in fact, DIANE, if you look carefully at some of the presentations today, you make a very good point that these presentations have been recorded. You can go back to them, and you'll see that in some of the cases that DIANE showed, there are cords attaching one of the valves to the septal crest. And this, again, is supportive of the fact that you can make the inference of ventricular topology, because the cords attaching to the septal crest identify the valve that is trying to be the tricuspid valve. So I think that if you are very careful, you can make inferences that one of the valves is trying to be a tricuspid valve. But I think overall, you are on much stronger ground if you call them the right valve and the left valve, because for sure, you're going to know whether they're right-sided or left-sided.
Correct. So again, I think you emphasized this point that you can't look at the atrial exit to define the atrioventricular valve.
Absolutely, absolutely. And that is a very important point you make, because next week, when we look at the dominant right ventricle, I'm going to be showing pictures of heart next week. You look into the floor of the right atrium, it looks for all the world like tricuspid atresia, but in fact, underneath that right atrium in the heart I'm going to show next week is an incomplete left ventricle, because there is left-handed topology. And so despite the fact that the right atrium looks like a right atrium, looks for all the world like tricuspid atresia, had the valve developed on that side in the setting of left-handed topology, it would have been a mitral valve.
Correct. I've got a number of echocardiographic specimens in my career that look like that. So I don't think it's that uncommon.
It's very nice that we have David Bolander with us. David, you're muted at the moment. Unmute yourself.
Hi, how are you, Bob?
How are you? Great to see you. It's nice to see that you're taking part in our discussions. For a moment, I had you on my screen and it said Diane Spicer. And
Yeah,
I thought,
I changed.
that doesn't look like Diane Spicer. I should tell everybody that David Bolander is an outstanding anatomist with whom both Diane and I have worked very closely. He teaches anatomy at the Medical College of Wisconsin. He's been doing it for very many years. And I've been collaborating with David over my recent visits to Wisconsin. And David has been incorporating all the work we've been doing on cardiac development. And he now teaches the medical students in Wisconsin, at Medical College in Wisconsin, in Milwaukee. He teaches them the real story. So David, it's great to have you with us.
It's nice to be here. Thank you.
Do you want to
see
make
you
any
again.
comments?
We missed you this year.
Well, that's one of the beauties of Zoom, because now we can spread ourselves all the way around the world.
It is. Yes, I'm.
Now
We're glad
Diane's with
to,
us as well.
There's
Good to see
Diane
you're
too.
back, Diane.
Oh yeah, I've been here the whole time. I just didn't have my video on. I love the terrible cow in the background, David.
Thank you.
And your pictures were spectacularly clear today. It was like you'd taken one of your great Nikon pictures of them, that they were that clear. I don't know what you did today. Pardon?
I think it's just a learning curve. I'm
well,
getting
it's great.
better as I go.
Anyway, thank you. It was magnificent, Diane.
You should also say, Norman, that we are indebted for the way that Sasha has put everything together, because Diane makes her presentations and she loads them up, and then I do my narration, and then Sasha has to link everything together. And today, Sasha, I think that you did a great job. It all flowed together very smoothly, and I think it made a very nice narrative.
Thank you very much.
Absolutely. Absolutely. Well done, Sasha.
Yes, when you have people like you making it, it's very easy. So it's a real pleasure. So, Bob, there are three big questions. Again, one is from Paolo Zelinsky. You know him very well.
Paolo is very good. I've already seen Paolo's question, and I think it is an excellent question. So for everybody, can everybody open their the box anyway?
Of course, they can
But
look.
Paolo is making the point that if you are going to say, and some still say this, they still doubt the fact that the incomplete right ventricle is really a right ventricle. If you're going to call it an infundibulum, then how can you say we're dealing with transposition? Because we define transposition as the aorta arising from the right ventricle and the pulmonary trunk from the left ventricle. So even those who say it is an infundibular outlet chamber are making the inference that that small chamber is a right ventricle. So Paolo, it is not precious. The point you make is not precious at all. It just points to the inconsistency of those who deny ventricular status for that small chamber. And I think what everybody has seen today, the pictures that Diane demonstrated to you, when you compare the incomplete right ventricle in tricuspid atresia, the incomplete right ventricle in the setting of double inlet left ventricle, it is the ventricular arterial connection that makes the difference in the morphology between the two chambers. But she also showed you that even when you have discordant ventricular arterial connections, when that apical component is extensive, it can look very much like what you have in the Holmes heart. So I think nowadays there is no question but that second chamber is the incomplete right ventricle, and people who are denying that, they have no justification in that. And that's why we should no longer be talking about single ventricle.
Bob, it seems to me that people that want to deny the status of a right ventricle to that are also denying embryology entirely.
Oh, absolutely. Absolutely. I mean, and that to me, and that David has picked, I mean, during the time I've been going through Milwaukee, he comes and he sits at my presentations there, and he keeps on asking me about the embryology, and he's realized, and he took on board totally the importance of the embryology, and that's what he now teaches the medical students. And we should be doing this from the outset.
Absolutely.
More people should be doing what David is doing and embracing these new topics and bringing them into the medical curriculum, because we have to start teaching the medical students from the get-go. Because if we teach them the embryology properly, they will understand congenital heart disease properly, and it's a sequence.
Absolutely. I think embryology is and your exposition of the embryology is the fundamental of describing the pathology. Without understanding embryology, you can't understand the morphology of the lesions. And then you get that into echocardiography and you can't understand that.
Absolutely.
There are a lot of confused pediatric cardiologists because of that.
So, Sasha, we have some more questions.
Yeah, there is another one from Jaime Halcon. Where is the rudimentary right ventricle most commonly located in double inlet left ventricle in relation to the LV mass?
This is
or left
a bit of a
anterior?
problem, because if you talk to morphologists, there's no anatomists such as DIANE or myself, we would see the greater majority in which the incomplete right ventricle is left-sided. It's carried on the left shoulder of the ventricular mass. But Norman, is that also the case in the clinical situation?
Well, to me, Bob, I've seen the outlet chamber, as Jaime said, most commonly to the left, but also on the right side, and also completely neutral in the front.
Absolutely.
So I think that as an echocardiographer, that's not a problem. You just recognize the outlet chamber, and then you can look at it in regard to where it sits with the dominant left ventricle. It's either to the front and the left, to the front and to the right, or it's directly anterior. Easy to recognize.
But we have David. There is some comments, David.
Excuse me?
Yeah, do you have some comments about the presentation, or what?
It's really, I agree with Dr. Silverman. You put it together wonderfully. It flowed so well between Bob and Diane. And
yeah,
it's so good to hear the discussion between all of you.
very good.
And I know the medical students dislike it when I tell them things that aren't in the textbook.
That is the real problem. And it is interesting there that I was reviewing a manuscript submitted the other day, and the manuscripts were citing something from the textbook, and I made the point, and David, and maybe you will comment on this, probably the textbooks are 20 years out of date.
Yeah,
Yes.
they are
I've been talking to some of the authors, trying to get them to make some changes. And
that's the
this
problem.
symposium, we're giving a symposium this year. The American Association of Anatomists meeting is virtual again this year, but they accepted our symposium from last year, in which Diane is given the key talk, and then Dr. Morey is going to be there too. And so we hope to reveal to them the real story.
So that didn't take place this year.
No,
Last year, the meeting was totally canceled.
Uh-huh.
This year, it's a virtual. And so
Right.
they allowed our symposium, or they approved our symposium to go on again this year. It's kind of a combination of some new ones and some ones that should have been given last year that
It
are
was
now being re-given this year.
As I recall, it was supposed to be in San Diego, was it not?
Yes. And
Oh,
this
what
year
the-
it was supposed to be in Indianapolis.
But I visited San Diego in February of last year, and I must say, what a delightful city. So it's a great pity you're not going to be able to be. I mean, I know Norman is in San Francisco, and Stanford is lovely, but I have to say San Diego was spectacular, Norman, in comparison to San Francisco.
Well, it's a nice place. I like it too, but I'll stick with Northern California. The intellectual climate is great here.
At least you have the Napa Valley that is in striking
That's
distance.
correct. Right around the corner. I can see the wineries from my home. Bob, I think that Dr. Salam has asked about straddling without overriding. I think the question becomes an important one echocardiographically, because there are few techniques other than morphology and echocardiography that allow you to see the tendinous cords. It's not easy with magnetic resonance imaging, and it's not easy with CT either. But I think that as far as deciding what to do in terms of a 1 or 2 ventricular repair, you have to see what percentage of the valve is committed to the ventricle and what the number of straddling of the tendinous cords is. We know that the surgeons, Sasha can talk about this, can transplant some of the tendinous cords so that if there's a problem, they can be done surgically. But when it becomes a real problem, that it's not possible to do that. And of course, the ultimate decision must be made for that by the surgeon.
Well, that's a very good point there that you make, Norman, because I mean, Sasha can comment on this also. But in 2 weeks' time, we're going to talk about straddling and overriding. And whilst it is the overriding that determines whether you have concordant or discordant or double inlet atrioventricular connections, for Sasha as a surgeon, the key point is whether the tension apparatus is crossing the crest of the septum, because you can't close the crest, the ventricular septal defect, if you have tendinous cords crossing the septum. So probably for the surgeon, the straddling is more important. But then the other consequence of this is the size of the second ventricle, because the ventricle, if most of that atrioventricular junction is going to be going into the big ventricle, the small ventricle is much more likely to be small. So the degree of overriding is also important with the flow into the chamber. So I think both are important, are they not? You're muted.
Yes, no, I agree with you. I think we've got that point well understood, unless Sasha wants to add a comment as the surgical view, because he's ultimately going to have to make that decision in the operating room.
You know, for surgeon, there is only one rule: biventricular repair for as maximum as you can. But as Bob said, I think that straddling is more risky than overriding. We are able to, mostly of the time, manage not severe, but some degree of overriding. But when the papillary muscle and the cord is on the other ventricle, then it will be very challenging to decide. I think that to do this type of operation, as much the patient is grow up, as much as you have the opportunity to play a role and transpose also the papillary muscle from one ventricle to another. But I think that mostly of the cases is very challenging.
Would you not say that it's easier when that transplant is going to go to the pulmonary ventricle rather than the systemic ventricle?
Yes.
I've certainly seen that in my own experience with working with Frank Hanley. The Gore-Tex cordi, etc., that can be put in the right side work a lot better than when they have to be in the left side.
But the point is also, Norman, there is a big experience about if you do a biventricular repair and then you have to reoperate for mitral stenosis, then obstruction of the aortic root, or to do, this is the Philadelphia idea, is better one single ventricle repair without operation in the life, or is better a biventricular repair with 3 or 4 operations during the life? Again,
I see, Sasha, that we've had another question from Mohammed Sharifuzaman, who says how to determine atrioventricular concordance in double inlet left ventricle. Well, I hope we've made the point that if you have double inlet left ventricle, then you cannot have concordant atrioventricular connections. However, you can have, if you are a Van Praguist, atrioventricular concordance. And that was one of the big problems that led to what I've identified as the Great Schism. Because one of the reasons that Dr. Van Praag and I did not see the same way early in our discussions is that I did not appreciate that for Dr. Van Praag, atrioventricular concordance is SD or IL, irrespective of the way the atrial component of the heart is joined to the ventricular component of the heart across the atrioventricular junction. So that is why now DIANE and I never talk about atrioventricular concordance. We talk about concordant atrioventricular connections or discordant atrioventricular connections. And so if you have concordant or discordant atrioventricular connections, it follows you cannot have double inlet ventricle, because double inlet ventricle is a different atrioventricular connection. So then the whole point about overriding of one or other of the junctions, depending on that extent of the override, you either have concordant or discordant connections, which are biventricular, or you have double inlet connection, which is univentricular. And Norman, I think you would now go along the same path, would they? And I think we've persuaded you that you should only talk about concordant or discordant atrioventricular connections rather than concordance or discordance.
Well, yes, I think that one can understand that Dr. Van Praag talks about alignment, and therefore that becomes easy when you talk about alignment to see what is lying over what. But that doesn't tell you about the connections.
Absolutely.
And what we are looking at in your sequential segmental anatomy is the connection of the atrium to the underlying ventricle. And that's what is important.
Indeed, because it's the connections that makes the blood go around. That's
correct.
That's as Willie Sutton would have said, that's where the money is. That's why I rob banks.
That's correct.
So, okay, thanks a lot. Bob, you want to introduce?
Everybody, great session.
Fantastic. Bob, you want to introduce next week?
So next week, we're going to be talking about the same sequence we've seen today. We're going to be talking about dominant right ventricles. So we're going to build the much rarer variant next week. Double inlet right ventricle is quite rare. So what we're going to introduce next week is we're also going to look at absence of the left atrioventricular connection in the setting of a dominant right ventricle, which of course is one of the subsets of hyperplastic left heart syndrome. So DIANE has already made presentations to show the difference between an absent connection and an imperforate valve. She's got an exquisite sequence of hearts that are going to show the consequence of override between double inlet right ventricle and atrioventricular septal defect with right ventricular dominance. And I don't know, has Adrian been with us today, Sasha?
Yes.
Is Adrian there? Can we get Adrian on board? Is Adrian going to be able to take any pictures?
We will see. Adrian is not here. Huh?
Is not here.
Yes.
I must say that just looking in retrospect at the way Sasha put this together, it was like the two of you had collaborated immediately, one with the other on these things, and yet these were done entirely separately. Quite a piece of production, Sasha.
Yes.
Not quite entirely separately. So DIANE has seen the PowerPoint for next week, and so she's going to correlate the specimens for next week. So we are talking to each other ahead of time. It's not entirely independent, but we hope that we might also get Adrian Cruchan to make some images of the Birmingham archive, but we're not entirely sure whether that's going to happen or not. But if it doesn't, then DIANE and I have enough between us, but we hope we're going to get Adrian on board.
I agree, though. It's like you were in the same room.
Yeah.
Well, good to see you all.
I think we've worked together long enough that it's like we're in the same room.
Yeah, right.
It's at the present time, I can only say it's a pity we're not in Florida, because I fancy the weather is a little bit better in Florida than it is in London at the moment. But as I look out of my window, the sun is beginning to shine, and our lockdown is going to finish shortly, so we're going to be able to get back on the golf course. But
Oh, there you go, Bob.
Yeah.
Were you going to have a mask on the golf course, or we're going to be able to recognize you?
no, they reckon we're relatively free on the golf course, so we're looking forward to that. But we've been locked up now for best part of 3 months, so we hope that we're returning slowly to normality.
So thanks a lot to everybody. Thanks a
Bye,
lot.
thank you.
A lot from all over the world, Bob. You see, we have friends now from 100% of the world. So we are very happy. Thank you, Diane. David, you are most welcome in the Congenital Heart Academy for the next week or whatever you are interested. Bob, see you on Tuesday for our tea time.
Yes.
I got my tea and you talk, and it's amazing. Norman, see you very soon, and you are completely inside the Congenital Heart Academy.
Thank you.
Thank you very much.
Great
Have a
to
nice
be
day.
here.
Bye-bye.
Bye.
Bye.